Thank you very much, Alison. Thank you for the invitation to come and talk to you all today, and thank you for being here. The title that's up in front of you didn't have the "and reducing" subsection in it before I got on the train this morning in York, but I added it because I'm feeling really depressed today about health and health inequalities in the UK. I hope I won't end on a completely depressing note, but I might, so I warn you in advance. But the reason I'm feeling a bit glum is to do with the fact that we have such a long tradition of thinking about inequalities in health in the UK, in investigating them, both academically and among policymakers, thinking about what we might do about them, commissioning reports, putting out sets of recommendations, and yet seemingly having very little impact on inequalities in health in our population. We were the first country in the world to start looking at inequalities in health because we started collecting birth and death registration data earlier than anybody, and we started measuring social class decades, if not centuries, before some countries, and being able to look at health by social class for a long, long time. We were the first country that had a national commissioned report on health inequalities that overturned the notion that health was at the top of society. That's what people thought before the Black Report. They thought that the highest risk of coronary heart disease was among executives because they suffered more stress. By the way, you can buy on Amazon executive stress formula in case you're still suffering from that non-existent disease. It's a herbal formula to support your ability to cope with executive stress. But most of the population, if not the purveyors on Amazon, have understood now that health is worse at the bottom of the population and that health inequalities are large. We had the Aitchison report in the 1990s and we had the Marmot report in 2010. They all examine health inequalities in detail across a range of dimensions, and they all make exactly the same recommendations. So that's quite a long period of time to be recommending the same thing and having to examine the same problem. And it hasn't seemed to have much impact. This report from The Guardian came out in January of this year, and The Guardian called it a landmark report. It was a report from the Royal College of Paediatrics and Child Health, I hope I've got that right, looking at children's health in the UK, and they called attention to stark inequalities and high rates of child death, obesity, and in health. They really made two main points, and one was that if you're in the lowest social class, your risk of your baby dying in the first year of life was twice that as if you were in the top social class. That's exactly the same risk ratio as we saw in the Black Report, exactly. They also pointed out that our child well-being is worse than comparator countries, rich developed nations in other parts of the world. Well, that was hardly news either. We've known that since 2007, when UNICEF first published its report on child well-being in rich countries. So in what sense was this a landmark report? In no sense whatsoever. We've known all those statistics for a long, long time. And this is why I'm depressed today. For those of you who've been in conference all day, you might not have seen this new report. Again, this is from the Guardian website. It came out this morning, 2nd of November. It's from the IFS, so a reliable, independent think tank looking at data, and they say that 37% of our children will be living in relative poverty by 2022, and that will undo all of the progress made in the past couple of decades. 37%. We should be deeply, deeply shocked. They also point out in this report that the gap between rich and poor will grow over the same time period. So whatever we have learned about how poverty and inequality shape people's life courses, shape their health and well-being from preconception through to old age, we're doing nothing about those major social determinants of health. And we're actually now in a setting, in a context, where health is deteriorating in the UK. And when I'm talking to public health practitioners, to researchers, I feel that awareness of this changing landscape is slow to emerge. Data are being accumulated looking at the impact of austerity on population health since 2010, and it's very, very disturbing, but I think there's still a lack of awareness. In most countries throughout the world, infant mortality rates are seen as a kind of a canary in the coal mine for public health, and in most countries throughout the world, they have been falling consistently for decades, falling faster in some countries than in others, but always falling. Our infant mortality rate has gone up since 2010 for those in the lowest socioeconomic class. Really shocking to see the impact of austerity written on the deaths of babies born to working class families. And our local authority budget cuts, the amount of money that our local authorities have to spend on protecting the health of the public, is being slashed across the board, but much, much more in areas where we already have high levels of child poverty. So this chart up the y-axis shows the cut per head in pounds of the local authority budget from 2010-11 to 14-15, plotted against the percentage of children living in poverty. And you can see that strong correlation in this admittedly cross-sectional data of the link between cuts and areas that are already extremely deprived. The coloured dots are just to show you that the largest cuts are happening in Labour-controlled local authorities versus Conservative ones. And it's not just children, of course. Many of you in this audience will be deeply familiar with this chart from the London Health Observatory, published a number of years ago, showing that if you metaphorically get on the Jubilee line in Westminster, in the centre of London, and travel out east towards Canning Town, you lose on average a year of life expectancy. So massive health inequalities within our UK cities, and also comparatively. Again, a lot of you will be familiar with this chart, which Michael Marmot often uses when he's talking. It shows on the far left the life expectancy for men in Carlton in the UK. That's an area of Glasgow. An average life expectancy there is 54 years, less than that on average for men living in India. And on the far right is another area of Glasgow, Lenzie, where the life expectancy is 82. So these huge and growing health inequalities are a real scar, I think, on our nation, and a real reflection of the immorality of political and policy-making processes to deal with real suffering in people's lives. There's the local authority budget cuts against premature mortality. So it's exactly the same picture, as you would expect if you look at the budget cuts against infant mortality. So that's the sort of the context in which I'm being a bit miserable. A context of severe austerity, growing health inequalities, and indeed a sort of slowing down in improvements in health for the rest of us. So Michael Marmot recently saying that life expectancy gains have slowed in the UK after, continuously improving. So I want to sort of switch now and talk to what it is that I think that longitudinal studies, cohort studies in particular, can help us to understand about health inequalities, focusing on my own work in Bradford. But I also want to finish by talking about what we need to do to augment those cohort studies to have a richer understanding of life course trajectories in health and well-being, and perhaps better evidence that we can bring to policymakers and politicians to get them to enact change. This is the prettiest photo I know of Bradford. which is a city I love and spend a lot of time in, but it doesn't normally look this glamorous. This is the new Millennium Square with fountains and lights, and we sometimes have Born in Bradford family events there, and it's all very nice. But a lot of Bradford looks a lot more like this. Back-to-back housing where people don't have gardens, they don't have safe places for their children to play, they're in overcrowded accommodation that's often damp, they are poor, levels of unemployment are high. Bradford is a city with a lot of social and economic problems, and indeed a lot of health problems too. We have an exceptionally high infant mortality rate, very high rates of disability among children, very high rates of asthma, and an impending diabetes epidemic, particularly among our South Asian population. High levels of child obesity associated with that. And it's a city that's changing very, very rapidly. So our ethnic social mix is changing. The economic circumstances in people in Bradford are changing as well. Born in Bradford is quite a unique cohort study. As a local cohort study, it's able to focus very much in depth on the determinants of health in the locality. It also is quite unique in being very connected to other sources of data and being willing to work with the local authority, local services to try and understand the context of health and development in Bradford. So like a lot of cohort studies, we collect all of that individual level data, including genetic data on children, but we're deeply interested in cultural factors, in inequalities, in how people are relating to one another in the city, and we're very interested in the environment, things like pollution and green space, physical activity, connecting those. So we take a very broad view of child health and family development. So we collect an awful lot of data. We collect a huge amount of data from mums. We collect a huge amount of data on babies. We're now really collecting a lot of data on children and as adults as they move through the life course. And the outcomes we're interested in vary enormously, and increasingly they're focused on socio-emotional well-being and educational attainment, as well as measures of health. And we intend to follow these children across the life course, funding permitting. Our cohort has over 13,000 births in it, families in it. We have some singletons, we have some twins, and we have some triplets, and we have some families in the cohort who've had more than one baby while they've been with us, which has allowed us, incidentally, to look at the impact of being in a cohort study on health in pregnancy. And although the data were not as statistically significant as one might have hoped, given to sample size limitations, it looked quite clear that participating in a cohort study is related to improved health-related behaviours in subsequent pregnancies within the cohort. So paying attention to people in any way is probably usually a good thing. Just a few of the things we've been able to find with our large local cohort study. We've been hugely interested in ethnic inequalities in health and well-being because half of our babies are of Pakistani origin. Some of them are third generation, some second generation. Lots of our parents have come to the UK from Pakistan, either mum or dad. More than half of our babies born have one parent from outside the UK. And we find that at birth, their children are smaller, they are more likely to have low birth weight, they're much smaller than white British children. But over time, we see them catch up very quickly, and by age 3, that dotted bottom line, the children of Pakistani parents are starting to be larger than their white British compatriots, rather, even though they started life off smaller. And as we know from David Barker's work and many others, looking at the impact of birth weight on long-term health, this pattern of growth restriction during pregnancy followed by rapid growth is the pattern most likely to lead to chronic disease in middle age. And so we're seeing ethnic differences in that patterning in our Born in Bradford cohort. We also are interested in the nutritional status of our families. We find that vitamin D levels are much lower in our South Asian families than in white European families. And we've been interested in a lot of quite esoteric dietary exposures, and the one I want to sort of mention here is acrylamides. So acrylamides are usually found in plastics and other manufactured things, but we also find them in food. And the kind of food we find them in is starchy food that has been fried at high temperatures. All of our favourite foods, in other words, so crisps and chips and anything that's sort of been deep fried and that's kind of starchy to start with. And working with other cohorts, as well as Born in Bradford across Europe, we found that acrylamide exposure in pregnancy is related to lower birth weight and smaller head circumference in the babies who are exposed. We've been very interested in air pollution, and we've found an 18% increase in low birth weight in the most polluted areas. That's per 5 micrograms per cubic meter of PM2.5, and smaller head circumference and birth weight associated with pollution. And this has actually allowed us to work with the local authority to change how polluting public transport is in Bradford. So we have been able to have a sort of a direct policy impact there. But that's really one of the few places where we've been able to say directly that we've produced a research finding and been able to take it to policymakers and effect a practical change that will change the exposure of babies being born in Bradford in the future. Because of our population, we've been very interested in cousin marriage. Almost all of our Pakistani origin families come from the same area of Pakistan, where cousin marriage is the norm and chain migration is very common. And we have high rates, very high rates of cousin marriage within the cohort. We don't only have cousin marriage in our Pakistani families. You might be surprised at the rate to which white British families marry their cousins. Proximity is everything, I suppose, for attraction. But we know that cousin marriage can raise the risk of having a baby with a congenital anomaly. We find that it doubles the risk of babies having congenital anomalies. Population attributable risk is 30%. And this has been very public and very controversial. MPs have asked questions in Parliament about these data. Should cousin marriage be banned? It's an aspect to which the population and lots of other people give a lot of attention, and yet still it's very, very tiny numbers of babies who are born with congenital anomalies. And other research that we have done has shown that cousin marriage has some positive benefits for family well-being in social, emotional, and economic terms. So having a range of data to be able to bring to bear on a particular question is very important. And I think this is one of the strengths of omnibus cohort studies, where we try to collect data about lots of different things. It's so we can take this balanced view of health and well-being. And if you have a purely medically focused cohort, you wouldn't collect the information that would allow you to do that. It does raise a real challenge for us when we're designing cohort studies, because you bring together a range of people who've got disciplinary interests in looking at particular associations between exposure and outcome, and they want their data to be gathered as optimally as possible. You know, they want the longer tools, the ones that have been validated the most. They want more time given in survey data collection to their areas of interest. And it's very difficult to balance everybody's perspectives and try to get enough data on enough things to be able to look at things in complex ways. But it's a challenge we have to meet. And in an era where people may be becoming less willing to spend significant amounts of time with researchers addressing survey questions. That's going to get ever more challenging. And I think it forces us to think about new ways of collecting the kinds of data we might want. And looking at sudden infant death syndrome, we found that our babies of Pakistani origin are less exposed to risk factors for sudden infant death syndrome than white British infants, and that Pakistani families avoid some of the risks and hazards for sudden infant death. So again, there's a complexity issue here. Our families of Pakistani origin tend to be more deprived than white British families, but they tend to have better health-related behaviours, certainly the mums, and certainly while they're pregnant. So we see a lot less smoking, a lot less alcohol consumption. We see better or safer behaviours in relation to sudden infant death risk. So we see positive and negative influences of ethnicity and ethnicity-related behaviours on the health of children. It makes it an interesting place to work, and it makes it one which I think throws up research findings that are applicable broadly to our very, very complex contemporary society, which is multicultural and multi-ethnic and exceptionally diverse. So we keep learning lots, and our original cohort born in Bradford continues to be fruitful. Alison mentioned that we have funding at the moment and are in the middle of a new wave of data collection with our families. We're collecting data in schools on every child in the classroom and not just the born in Bradford children, because it's too difficult to figure out who is who. So we're actually nesting a massive cross-sectional study within our longitudinal cohort study and looking at how children's educational and social and emotional development is progressing. But we're trying to collect longitudinal data on our families as well, anthropometric data, we're collecting bloods, we're doing all kinds of other physiological measurements, we're administering questionnaires, etc. So we'll continue to learn from Born in Bradford. But I wanted to turn now to what else we need to effect change, because it's not enough just to learn more about how an exposure is related to an outcome or who it is related to that outcome for. What kinds of causes might be relevant to different populations in terms of trajectories of health and well-being. Having that information doesn't seem to have allowed us to make the change we want. And we are better at cohort studies than anywhere else in the world. We've been doing them for longer. We spend more money on them. A huge amount of intellectual effort and resources go into our cohort studies, both national and local. And yet here we are, with 37% of our children about to be living in poverty, inequality growing, etc. So I've been thinking hard about what else we might need actually to enable us to make that transition from being excellent researchers to excellent advocates for change and successful campaigners, so we actually see the policy changes enacted that will produce the health benefits and the reductions in health inequalities that we're all seeking. I think there are three areas where we can augment our longitudinal studies with different kinds of evidence that might help to make a difference, although I'm not completely sanguine. And when I was on the train, I actually thought of a fourth. So if I don't get to remember that, sort of towards the end, ask me about it in questions. One is that I think we need more detailed information that we can get from a cohort. When we're doing cohort studies, we're doing bespoke data collection, we need people to spend time with us, it costs a lot of money. You all understand that picture. But there are rich sources of data elsewhere that we can link to our cohort studies to give us a fuller picture of what's going on. We also need more evidence that if we intervene on the exposures we have uncovered in our longitudinal research, if we change them, we can actually cause better outcomes in our families that we're following. And I think we also, and I think this is more of a political point than a sort of an academic point, we need more evidence to show to politicians and policymakers that there are alternatives to how we do things in the UK and how health can be achieved for a population. And so I think we need more comparative work. I want to give you one example from our Born in Bradford work about the value of linking cohort data to routinely collected information. And the chart I'm showing you, these data come from a study that I did with Dr. Stephanie Prady at the University of York. And we were looking at mental health, common mental disorders in pregnant women in our Born in Bradford study. And what we had collected on all of those women was a measure of mental distress using the GHQ-28, which for all its flaws has its uses. So we knew in our cohort study which women in late pregnancy were scoring high, above a threshold, on a measure of distress. And what we were interested in was then going and looking at the medical records to see which of those women had actually been diagnosed, referred, or treated in the healthcare system if we thought they were distressed, or treated when we thought they were not distressed, and we wanted to look at that by ethnicity. Now, this was a study with a huge amount of technical challenges, linking cohort data to routinely collected medical data, whether it's from primary care, like here, or whether to hospital episode statistics, is a nightmare. You need really good technical people, you need a lot of time, and you always need to do it over and over again because you always make mistakes the first time. You have to make assumptions about the diagnostic codes that you're interested in. You usually have to ignore some of the rich sources of information in the routinely collected data because you won't have access to the notes that GPs scrawled, only to things that are entered into systems. But what we found is when we looked at the primary care record, there was a much higher prevalence of common mental disorders being diagnosed or treated or referrals given for them among white British families than among our Pakistani families. But when we looked at our measure of distress, we saw much higher levels in Pakistani origin mums than we did in white British families. And in fact, you are half as likely as a Pakistani woman to have had a diagnosis, referral, or treatment for a high level of distress as a white British woman was. So that study enabled us to use data from two sources to understand a problem, I think in much more realistic terms than if we'd had either data set alone. If we'd only had our cohort data, we would have been making one kind of assumption about who was most distressed. If we'd only had the GP data, we'd been making a different assumption. In fact, we were even able to see that the kinds of treatments given to different ethnic groups varied. So that starts to allow us, I think, to make some recommendations that affect practice in healthcare that we wouldn't have been able to do if we only had one data source alone. There's a lot of interest at the moment in the UK in the potential of data linkage and big data. It's a rather dangerous move, actually, because I think there are people who believe we could all stop doing our cohort studies and our longitudinal studies and just rely on routinely collected data. It isn't good enough. The data are not good enough. The linkage systems are not good enough. And neither system alone will give you the richness and the complexity that you need. So accessing big data, linking to routinely collected data is the solution, not replacing one with the other. And we need to stand up for ourselves in that regard as the funding landscape changes, and we need to keep on making a case for that rich complex data we get from sitting down and talking to people, or giving them long, boring survey instruments, or collecting biological data from them, in comparison to what's collected in the health service, in schools, in social services, etc. But when we bring the two together, we potentially learn a lot more. The other thing I think would help is if we can, as a community, start to produce more evidence that when we intervene, we can actually make change. And Alison mentioned that I'm now the director of the Better Start Bradford Innovation Hub. Well, it's born in Bradford's Better Start Bradford Innovation Hub. It gets to be quite a long acronym. And Better Start Bradford is funded by the big lottery. They have funded 5 places in the UK to do interventions with pregnant mums and 0 to 3-year-old children to see if they can change their outcomes at age 5. So that's the basic Better Start structure. They are funding us in Bradford with £49 million over 10 years. So this is a huge investment. And fairly similar amounts in Blackpool, Nottingham, Southend and Lambeth. So all of these are areas with different kinds of challenges of poverty, inequality and deprivation. And they're asking the question, if you put a lot of money into a local area and you do a lot of things to try and improve health at age 5 by focusing on pregnancy and 0 to 3 years, can you improve children's nutrition and prevent obesity? Can you improve their language and communication skills? And can you improve their social, emotional well-being? So Better Start Bradford is located in 3 of the most deprived areas of Bradford, Bowling, Barker End, Bradford Moor and Little Horton, rather than the whole city. And that £49 million is being mostly spent on doing the interventions, on offering services to pregnant women and families with young children. And our innovation hub is using a little bit of that money to try and evaluate whether it makes a difference. I've only put this up not so you have to read the small print, but to remind me just to discuss what a complex kind of study or innovation this is to put into place. So it's a collaboration between those of us Born in Bradford who are researchers, so researchers from lots of universities, with Better Start Bradford, which is the service delivery community partnership. We have cross-cutting themes, we have work streams that are related to the outcomes that Big Lottery are interested in. Better Start Bradford have named their interventions as Bump Start Your Baby, obviously about pregnancy, babies and bonding, falling in love with your baby, talking together, eat, live and love, and Better Start, Better Place. But in each of those areas, there's lots of interventions. And some are for everybody, and some are for particularly at-risk families, and some have started already, and some have not yet been commissioned, and it's a hugely complicated effort to try and see what's going on. So what we're doing is taking the Early Intervention Foundation ratings, and the Early Intervention Foundation classifies interventions by the evidence that underpins them, and we're going to try and take all of our named interventions, some of which are well known, some of which are bespoke, some of which have not yet been invented, but we will try and nudge them up the Early Intervention Foundation ratings so that there's a better evidence for all places in the UK to use when they're thinking about what to do. When we looked at the evidence base for early interventions, we're really shocked actually by its poor quality. We were asked to include in the bid only interventions that either had a proper evidence base, by which they meant there's a randomized control trial showing that it works, or science-based, which basically meant it's a good idea. There's a logic model, or there's a systematic review, or there's a before and after study, or it's a good idea. We only found 2 evidence-based early interventions appropriate for our population. One was the Family Nurse Partnership, which a separate study has now shown is not effective in the UK, and the other is undergoing a trial at the moment, which will probably show the same thing, I'm afraid. But we need to improve that evidence base if we're going to make the case to policymakers that they should be intervening at these early ages. So we're monitoring everything that's going on. We are evaluating how different services are being implemented. We'll do before and after studies for those interventions that are not yet ready for a full effectiveness evaluation. And we'll be looking at how ready the community is and how they engage in different programs. And we'll hope to get some answers about what works. And to be able to do this, we've had to set up a new cohort study. So we have a new cohort study in Bradford called Born in Bradford's Better Start. We're recruiting 5,000 families over 5 years. We're a year in. And that cohort will act as our platform for looking at interventions. As far as we know, it's the world's first experimental birth cohort designed to be a platform for evaluating interventions. I'll skip that one in the interest of time. We're going to do a lot of quasi-experimental work, but we're also going to be doing trials within our cohort, Twix, where we consent women when they join the cohort to be randomized to receive services or not later on as they go through their family growing up journey. So we will randomly assign them to receive an intervention or a control, usually using waitlist methods and then using routine outcome measures to see how they're doing. So this is a huge effort to try and build evaluation of interventions into a longitudinal research setting. The third thing I wanted to mention was how important it is for us to be able to put the research we do with our longitudinal studies in an international context. And the reason I think that's important for policy is it means that we can show policymakers and politicians that it is possible to do things differently elsewhere. It's very difficult to do cross-cohort studies. You have to harmonize your data. It's very, very challenging. You'll go to another cohort study in another country that looks very similar to yours and find that they collected data at a slightly different age point, or they didn't ask quite the same question about income, or they measured outcomes slightly differently, or they included everybody, or they actually did some kind of complex sampling. So it's very hard to harmonize, but when you can do it, it can be illuminating. This is just one chart from the PhD dissertation of a student of mine, former student, Dr. Pippa Bird, who looked at child health in Canada, that's the UCLS, in our UK Millennium Cohort study, in the Australian Longitudinal study, in Generation R in the Netherlands, and in ABIS, which is all babies born in southern Sweden. And what she was interested in was looking to see if measures that are really good predictors of how well children do over their lifetime had a different social gradient in different countries, as well as a different average prevalence, and whether that was related to income inequality. What she's looking at here is height, which really does predict health long term, and we find steeper social gradients and lower heights in the more unequal countries that we looked at. So this is the kind of evidence that we need to be able to bring to policymakers and say, everything in the UK isn't great, and it's not a natural phenomenon. Other countries do better. I just put this one up because data on social mobility sometimes come from longitudinal studies. They certainly do in the UK. In other countries, they come from national record collection. But we've been able to show, and other researchers have as well, that equality of opportunity, the levelness of the playing field, is affected by equalities of outcomes, how much income inequality there is in a country. And you have to be able to put your lens at this international level to be able to look at this question at all, and to be able to say there's a problem in the UK. We don't have the social mobility that our counterparts have in France or Germany or Finland or Denmark. So as well as focusing on our own studies, we do need people who cast that wider lens and look at how we do nationally in comparison to other countries. So we need more data linkage, we need more big data, we need more interventions and evaluations within longitudinal studies, and we need more comparative cross-cohort studies. And the thing I forgot is we need more qualitative research embedded in our cohort studies, and we need longitudinal qualitative studies as well. There's a danger if we don't do something about the massive health inequalities we have in that nation, and that is the danger of what happens when people feel left behind, isolated and excluded from participation in society. This graph comes from The Economist, which is not my favourite progressive left-wing organ, but they responded to a Twitter challenge which asked, what is the factor most closely correlated with the swing from Democrats to Republicans? What was it that got Donald Trump elected? And what they found was that it was a measure of health, basically health inequality. These are US counties, and they're looking at a weighted index of obesity, diabetes, heavy drinking, lack of physical exercise, and low life expectancy. And it was the counties with the worst health that were more likely to swing from Democrat to Republican and vote for a president who was most likely to take away their entitlement to health insurance. But when we isolate and socially exclude people, including in terms of their health, we do create an anger and a sense of distress that can actually act against our being democratically able to undertake the changes we need to make to improve the health of the people who are suffering most. I'll stop there, and I'm sorry I went on a bit. Thanks.